Perfect. So we'll get started and I have some questions, but you are welcome to ask, I mean, talk about or go in any direction that you want because you have such a wealth of knowledge. But we'll just start with some basic information. So, can you briefly describe your name, give us your name, describe your medical background, area of expertise, and where you practice?
Yeah, so I'm a medical doctor. I'm Georg Northoff. I'm a medical doctor. I'm also a philosopher and neuroscientist. I have a degree in all fields. As you hear probably from my accent, I'm originally from Germany, but now I'm since 15 years in Canada, hold a Canada research chair here for brain and mind. And as a resident, I already detected some patients with catatonia and was fascinated by that symptom because directly it's the interface between brain and mind.
And so, can you say any more about how you became interested in catatonia?
Yeah, so I saw some patients early in my residency, and what particularly struck me that the movements, usually you would compare catatonia with, let's say, Parkinson's disease. Yeah, the akinesia when people can't move. But in this case, that the akinesia was simply different, and it was also accompanied by certain psychological subjective experiences. For instance, I tell you one example, very tragic case. Each time one of my, she fell in love, she became catatonic. Why? She couldn't control the intensity of her emotions. Yeah, of course, often it's anxiety, but let's say when you have strong paranoid delusions like in schizophrenia, or when you have a death, when you feel the death coming, when you're severely depressed, but it can also be positive emotions. So it's really the individually meaningful life events and how it affects your emotion and your control the emotion. That seems to transform into these movement changes.
I completely relate to what you just said. I'm a coach and I do trauma-informed coaching, and there's a equal activation, on a positive side than on the negative side. And we only have capacity for so much in our body. And when we hit over capacity, illness occurs. And catatonia is one of the reasons why I feel very strongly about that.
So this was for me one of the most fascinating things is subjectivity, the meaning of the symptoms. Yeah, the motor is not just like a pure motor symptoms like in Parkinson's patients, but it's really the symptom has a meaning and is relation to the subjective biography. That was for me the most impressive thing, and that's why I developed this psychomotor concept of catatonia. It's not just a motor disorder like dystonia, like tremor, like Parkinson's, like Huntington, with some secondary psychological manifestation. No, it's a primary psychological which transforms into motor changes.
So if someone didn't know what catatonia was, how would you describe that to them?
Catatonia is a behavioral and a motor response to certain emotional and cognitive changes, to extreme cognitive motor affective emotional changes, which are at the limit of your capacity, and you have no chance of other than reacting with the motor response and don't move at all or completely get out of control. So it's a genuinely psychomotor disorder, not just a motor disorder.
And I think this sort of has us move into your rating scale and talking about like how you developed it, why you developed it, how what your rating scale does. Um, and you could even, if you want to, like say why it would be more superior to use your rating scale than other rating scales. Like I'm open to anything you want to say about your rating scale.
Now I have to do the marketing for my rating scale. I'm joking, but
maybe we need to do that.
So you already said that clinically I observe this psychomotor, yeah, the close relation of your movements when you move to emotional and cognitive events, experiences. So that's why I said, okay, it's not just motor and behavioral. That's why I included the affective dimension as a third dimension into my rating scale. So in our Northoff Catatonia rating scale, we have 3 dimensions: motor, behavior, and affective. And that distinguishes our scale, for instance, from the Bush-Francis scale, which has only motor and behavior. And historically, you know, as a German, you always look into the history. That also goes with the original descriptions by Karl Kahlbaum of catatonia. He included also all 3 affective, motor, and behavior. Then the affective were somewhat forgotten, actually, in the European tradition with Krepler and Bloilin, and it was reduced to a motor and maybe behavioral symptom of schizophrenia. Whereas in the American tradition, which was quite interesting, Kirby 1913 already emphasized the affective dimension, yeah, and also the occurrence of catatonia and bipolar. And in parallel to this Northoff Catatonia rating scale, we also developed sort of a instrument for subjective experience of catatonia, which was recently put into an operationalized, quantified, standardized scale, subjective experience scale of catatonia by the Mannheim Group in Germany. And that really tries to account that the role of subjective experience, for me, is very important in understanding the symptoms. And that also gives you an idea about for the brain research, because you need to, in your brain research, you need to account for these subjective experiences. So it's, and that also bridges the gap to the client, because the client comes to you not because of the symptoms. The client comes to you because of the subjective experiences.
So, you know, can you talk more about your rating scale? And, you know, one of the things, like, I don't, you know, in the British consensus guidelines for the management of catatonia, like, they speak very highly of your rating scale. And I think their one downside is that it takes too long, which is a sad commentary on medicine, in my opinion. So can you speak to, like, you know, anything more you want to say about your rating scale and that comment that it takes too long, potentially?
Yeah, so I think first we try to, the rating scale really tries to account for the complexity of catatonia and try not to reduce it. So that's where reduce it to motor behavior really gives strong aspect to the emotional component and of course to what you subjectively experience. Because there's a certain tradition in psychiatry which really tries to understand the patient from the first person perspective of the client. And that's what I'm trying to do in my research. Now, and then we in parallel developed the subjective scale. Now the argument is too long, it has 40 items. Yes, yes and no. From a clinical perspective, I can understand that. And maybe it would be good if we establish a short version of the rating scale. Let's say maybe it's actually a very good idea. If somebody is interested in that, we can basically look at the current studies. What are the most highlighted items in each of the 3 dimensions, affective, motor, behavior, and then make a short version of that. And I can understand if you're in the emergency, you don't have time for 40 items. If you're in the emergency, you want something quick. Maybe we can, indeed, it's a good idea that we make a short, quick, applicable version, maybe with 10, 15 items. That's indeed actually a very good idea and could be a very good research project for the future. I agree with that.
And then when you're, and one of the problems for sure here in the US is, I don't know what it's like in other countries, but insurance companies are not paying doctors for more than, you know, 15-minute or 30-minute or whatever consult. And so it's hard for them to justify spending enough time getting to know the patient.
Yeah, very good point, and you will get a very elaborate answer from my case. Go into cardiology and cancer medicine. You come, you see the doctor for half an hour and a nurse, and then you have 2 or 3 days of diagnostic. You get an EKG, you get an X-ray, you get an ultrasound, you get a cardiac challenge task, you get all kinds of blood stuff, you get all kinds of X-ray, you get an MRI. Then you get a diagnostic. And then you can make a personalized therapy. For instance, now in the cancer medicine, they try really determine the antibody and say they do an immunological vaccine for the cancer cell. It's a BioNTech, the company which did the Pfizer vaccine. So this is really precision-based, personalized medicine. what can we do in psychiatry? Nothing. We have no clear diagnostic criteria, no objective markers, no personalized therapy. I'm sorry to sketch it as harsh as I do. And we are trying now, based on this, we have developed a spatial temporal model of psychiatric disorders. Catatonia is one. Depression is, for instance, a speed disturbance. The brain is too slow. The emotions are too slow. The thought are too slow. And you can't imagine the resistance. And we developed certain diagnostic markers for that. EEG, rating scales, fMRI. You can't imagine the resistance of people just to insert a half-hour diagnostic challenge test. It's unbelievable. We really need to change our attitude if we want the psychiatric therapy and diagnostic to be better, more personalized, more effective, and in tune with the standards of other branches of medicine. I'm sorry to say it as clearly and harsh, but I put my full weight, and insurance companies have to change. Why? Because they pay much more money if the patient enters the myriad labyrinth of the different health professional, different offers, pharmacological, non-pharmacological, psychotherapy. It's a huge market, yeah, where people have a lot of slices in the pie, and nobody wants to give that up. That really has to change.
Thank you for that. I'm wondering, when your rating scale is used, do you ask, because the patient often can't answer, the questions, do you defer to, or do you ask, the caregivers and the family for information to include in that rating scale? And can you talk about that?
Yeah, definitely. Of course, in catatonia, if you have a patient who doesn't speak, who is completely mute, who probably postures, you can observe. Of course, you can have a fine-grained observation, but of course, you need to include the caregiver and the relatives. Absolute key also, because you need to have the development. So for instance, for me, often is also important, was there a significant life event? Yeah, so for me, part of a psychiatric exploration is always environmental context. Was there a significant life event? Maybe I failed my exam, but what does it mean for your daughter to fail an exam? Yeah, the whole world broke down for her. That's probably the only way how she could react with the catatonic symptom, because she couldn't take the emotional pain. So I think that's extremely, extremely important to explore that. And I think, coming back to your earlier question, I think it would indeed be a good idea to condense the rating scale to certain key items which you can look for in the emergency room. I agree with that. Yeah,
And then when
that's where probably you see most often catatonic syndromes. Yeah, they come into the emergency room and then nobody knows what it is. And then finally the psychiatrist is called. The psychiatrist is always at the end when others don't know.
So also when there's patients who, have an excited form of catatonia, and I'm just going to tell you from our experience, like people believed what she was saying. And she was just completely bonkers, I mean, she was spiraling and saying, maybe there's elements of truth to what she was saying. I mean, she was like what you were talking about. She was like in doom and gloom and my world is over and I should have never taken out student loans. I shouldn't have been a teacher, blah, blah, blah. And then saying things like, she would say, I didn't do my own schoolwork. My mom did it for me. And they were all looking, like in college and university, and they're all looking at me. And I'm like, she's got catatonia, like you're believing what she said. And so they didn't ever ask me for input. They just based it on what was happening with her. And so can you speak to, like, even in an excited form of catatonia, how important it is to get family and caregiver input?
Yeah, even more important and more difficult probably to convey. And I think what really is important point that we do not just address psychiatrists, but we also address emergency room people, because that's where catatonia occurs. That's where there is the first stop often. Yeah, so I agree completely. And inclusion of the relatives is key. Otherwise, you cannot understand, and you cannot also distinguish us from a Parkinson. You don't see the cause. Parkinson starts slowly. Catatonia can start right away. So it's very important because for the subsequent therapy.
And you just like adding on to what you just said about catatonia starts right away. Can you talk more about that? Because that's not really spoken about much in terms of that it comes on suddenly and
Yeah, I mean, as always, you can have both kinds of development. So we really distinguish between a more affectively driven form of catatonia. This can be hyper-excited or hypo-excited, which usually responds very well to lorazepam, and that usually comes on relatively quickly. So you might have a depression before, you might have a bipolar disorder before, and then suddenly you become catatonic, or you can also first symptoms right away catatonia. And then you have more sort of the chronic catatonia, which is probably more treatment resistant to GABAergic drugs like lorazepam. And that usually comes on more slowly. Yeah, so you see precursors, you see slow movement, and then suddenly they end up in a completely catatonic state, which can be in very severe forms of depression. You gradually slip into the state of catatonia. Yeah, but I think that's very important. The time course of the symptoms is the key, because that gives you some differential diagnostic hint.
perfect. And then I just had another question based on that. Lost it. It'll come back, I'm sure. So can you share what studies you've done, what studies you're involved in, research studies, whatever what you think is important, in terms of brain research? I know that's something that's really important to you.
So based on these clinical descriptions I made, we really studied, we developed this rating scale. As I said, we compared the subjective experience in Parkinson's patients with akinesia versus catatonia and say, okay, this is really different, the psychomotor versus motor. And that sort of led us really to this concept of psychomotor versus, sorry.
No worries. We can get rid of it.
Hello? Okay, fake call. Okay. So based on these clinical observations, we really developed this concept of the psychomotor versus the motor, so that affective cognitive experiences, events translate into motor behavior changes. And accordingly, we developed this scale. We developed the scale for subjective experience. Then we also developed a test with a ball throwing test. And then we also did corresponding imaging data, fMRI, EEG, and said, okay, this really seems to be, for instance, the orbitofrontal cortex, or subcortically could be the rougher nucleus, serotonin, which then modulates dopamine. So we could really see, okay, the motor cortex is just the output, but it's not the source. And we have now recently paper also psychomotor versus motor, where we directly compared these two hypotheses. And it's really clear, you have motor cortex changes, no doubt. You have subcortical basal ganglia changes. You have probably dopamine changes, but these are secondary to some other changes in cortex or other subcortical regions, like, for instance, rougher nucleus, serotonin. So that's why we speak of psychomotor mechanisms. And I think that's very important for treatment. So this is diagnostically important because you can use some of these markers. That's what our hope is, for differentiating a primary movement disorder, extrapyramidal disorder like Parkinson's or dystonia or tremor or even Huntington from catatonia. Yeah. And so that's what we hope that we're now working on, that we really try to develop. Maybe we can use one of these psychomotor mechanism connections between cortical regions and the motor regions, or modulation of dopamine system by the serotonin as biomarkers for catatonia, as distinguished from, let's say, other disorders, pure psychosis without catatonia or depression without catatonia.
my question came to mind. I'm just wondering, in your experience, because when we exhibited at the American Psychiatric Association meeting, and it was interesting the comments we would get sometimes that they're like, yeah, we know catatonia, it's schizophrenia, or catatonia doesn't exist anymore, or they kept saying to my daughter, like, what was your underlying diagnosis? And she said catatonia. They're like, that's impossible. What are your thoughts about, because I know it's it's a disorder, it's various symptoms that make up catatonia. What are your thoughts about, whether it's, that it always presents from something underlying, or there are cases where it doesn't? Like, what are your thoughts?
You probably get as many answers as people you interview. Yeah, because it's such a. So, my view of catatonia is really a syndrome. So, it's like fever or jaundice or diabetes. You can have various ways for diabetes. You eat too much chocolate, you have a primary diabetes, you have other disorders. Jaundice, you can have drunken too much alcohol, or you can have hepatitis or other forms of liver disease. So same thing here. So my usual comparison I might say it's really there's an old saying in the ancient Rome, all roads lead to Rome. So here, many roads lead to catatonia, meaning, and I think the main affecting factor here is really probably the emotional cognitive capacities. Yeah, because many disorders, how to cope with a disorder, puts you into the cognitive and emotional extreme realms, how to cope with it, and that then transforms into catatonic syndrome. So for me, it's really a syndrome, a final functional pathway into which many disorders, organic, bipolar, mental disorders, and so can converge, like fever.
Thank you. That's excellent. So are there any remarkable recoveries that, stand out in your mind that you're willing to share? Obviously not with names or any specifics, but are there remarkable recoveries?
I remember I got the 24-year-old girl, suddenly from one day to another, severe catatonia, completely akinetic, completely mutistic, posturing, sometimes hyperkinetic episodes, short in between during the day, massive, extreme. And we treated her pharmacologically and all kinds of stuff, and then she developed fever. And I don't need to tell you, fever / febrile catatonia, life-threatening. So that's something that goes back to Stauder 1934, who described these cases. And I don't need to tell you, and I'm sure Max Fink talked about that too. That's if you have fever, immediate ECT. So we did 50 sessions of ECT. And finally, we could get her out of it. You cannot imagine, I was really relieved. Yeah, and now she's fine. I still have contact with her. And she never had a catatonic episode since. But of course, it was related to a life event, to the meaning of the life event. Basically, her personal world was broken down because her boyfriend separated. And that had a very special meaning for her, which I don't want to go into further detail. Yeah, so I was really happy, trust me. Yeah.
Anything else? Another one you might want to share?
Yeah, I mean, I had this woman with the, which I mentioned earlier, the patient, each time she fell in love, she developed catatonic syndrome. And then she knew that she reacted very well to lorazepam. So what we did then, I did that on my own response, on my own, so that I said, okay, you always carry some lorazepam with you. And when you have the feeling you get emotionally out of control, or it's too intense, you're too happy, you take a little bit preventive lorazepam. And it worked. She never developed another episode, and she came to me and said, thank you very much for doing something which probably no other doctor would have done. Yeah, but it helped her, and she was a very responsible person, so you can work with her.
I just funny. I just want to hug you right now with everything that you're saying. Everything I believe, but really the more traditional, because you are definitely not traditional, the more traditional medical doctors think I'm crazy, and I know that I'm not. I know that it's when the body does not have the capacity to hold what the activation that it you get sick.
Yeah, exactly. And you experience. See, this is where my experience-based approach come in, because I trust your experiences.
Thank you. So, um, what role would you like other medical what would you like other medical professionals who might not be familiar with catatonia to know about it? So we're talking about ER, ICU, internists, you know, the I forget what the doctors are called, intensive, the ones that come around and when you're in the hospital, all of those, and nurses and psychologists and anyone else. What would you like them to know?
So in the same way, I need to know as a psychiatrist, when there's fever, there might be something seriously going on in the body. Yeah. Then I order immediately a blood lab, and then I call my internal medicine colleague. Yeah. But I already provided the blood lab to give the internal medicine colleague some idea. Similar, so I would like to my colleagues know that they know, okay, there can be this strange, let's say, movement stuff, which can have a psychological cause, origin. You need to call the psychiatrist. That's all. Yeah. Of course, then they probably need to work together to exclude neurological origins, like encephalitis, virus infections, other things, because it can also be associated with organic. But don't deride the power of your psyche. Internal medicine people or medicine people in general say, oh, it's just psychological and then it's just derogatory. No, it's everything how you perceive things. That's very, very important. So just the power of the psychological, your experience, and that can by itself lead to certain symptoms like catatonia. Call the psychiatrist or the psychologist. Or call the Catatonia Foundation, even better, because they are the real experts. Yeah.
Yes, thank you. Thank you for the shout out. We appreciate that. So I'm wondering what you think if there's a role of like substance abuse in catatonia.
As again, has a history in the history of catatonia that has been discussed. Definitely yes. Again, now all the psychedelics are back in fashion. I'm sure Max Fink vividly remembers the time in the 70s when everybody took them. And now we are back to that in a more controlled way, admittedly. But I can really, really be careful. So here in Canada, we have complete liberalization of the cannabis, and you have cannabis shops everywhere. When you're in the downtown of Ottawa, you smell it everywhere. And cannabis can induce psychosis, can induce depression and catatonia. Why? Because these drugs lead you to extreme psychological spaces. They map the whole continuum of what is possible in your psyche to the very extreme. And if you don't have the right, proper psychological context, you might experience these psychological adventures as anxious and fearsome. And then you get out of control, you develop a catatonic syndrome. And I've seen actually quite a number of patients with exactly that. Very sad. We have also, I work here with the post-traumatic stress disorder clinic with the veterans. And you probably may know that for PTSD, post-traumatic stress disorder, cannabis is used a lot. And many of them are completely addicted, completely closed. We need to basically work on 1 year of just withdrawing the cannabis. So it doesn't mean that I'm against cannabis, but in a careful way. and in a controlled way under expert guidance.
Yeah, one of our board members' daughter, it was a variety of factors, but cannabis played a factor. And after she was cured, she smoked weed like a couple times in a week or a few times, and her catatonia started to come back. You could see it. I saw her, and I'm like, you are completely crazy again. And then when she stopped smoking, it went away, but it's very dangerous for her.
Yeah, definitely. I mean, I think it induces extreme psychological experience, positive or negative, where you have no control. Yeah, and I'm not wondering.
So I'm loving this interview. I'm so happy you agreed to it. Thank you so much. So are there any misconceptions in psychiatry about catatonia, and what do you think can be done to overcome those misconceptions?
Yeah, very important point. When I referred earlier that you better call the Catatonia Foundation, that was exactly my background reason, because many psychiatrists don't know it. They say it's just motor schizophrenia. They don't know that they can use lorazepam because it hasn't really entered textbooks yet. And it's also a gross neglect of the psychological dimension of it, as paradoxically as it sounds. Current psychiatry teaches these psychiatric symptoms in a very objective way. You have cognitive deficits, you have emotional deficits, but yes, you have them, but it's important how you subjectively experience this. And catatonia is all about that. Yeah. And I think that's the key. And so first, I think more awareness. It needs to enter in textbooks. It needs to be said it can be treated in 60 to 80% very well immediately with lorazepam. One of the few disorders in the mental realm where you can do this. It's unique. Maybe the ketamine in acute suicidal depression, but otherwise, I don't know of any other psychiatric disorder with such an immediate therapeutic benefit, and the psychological side of things. And also what is often neglected, the motor component. Or let's better say the psychomotor component. In depression, you can see when depressed patient, the spouse already knows 2 or 3 weeks before the onset of the cognitive and affective symptoms, the facial mimic becomes a little less. They walk like this, it makes themselves small, the speech is a little lower and slower. So it's all there already. That could be a marker, a marker for early detection. So the motor psychomotor component is grossly neglected in psychiatry because the background, also the historical background and also the current background, that these are higher order disorders of higher order cognitive or emotional functions. No, all functions in the brain are affected by mental disorders: motor, sensory, affective, cognitive, social. Yeah, and you can see that. I think that's important.
And when we were at the APA meeting, the younger generation is much more aware of catatonia, and super excited about the fact that, like, if we make a diagnosis, we have a treatment. So that was really fun, like, to see how excited they were. And these are, mostly the ones who had like done some, were in, and or they were fellows or residents who had done some training, in a place that recognizes catatonia, like I can't think of the place in Nashville, but that's a place that they have a lot of catatonia research. But they were not one of them felt confident making a diagnosis of a more of an excited form of catatonia. So I'm wondering if you can speak to that. How can they feel confident making an accurate diagnosis in that case?
Yeah, I think they need to see the symptoms, the echolalia, I remember the mitgehen, mitmachen. I remember one of my patients, actually happened quite recently. She followed me throughout the whole hospital all day. Yeah, mitgehen, mitmachen, because they completely lost their own internal initiative. Yeah, they completely were stimulus locked external. And lorazepam didn't help that much. Later, we gave her ECT, and that helped. Yeah. So I think one needs to be aware of these symptoms. And they're probably the opposite. I think catatonia, of course, obviously is an extreme state, but your body or your brain oscillates between extreme states. So completely still stand or completely, let's say, all over the place. Yeah, hypo versus hyperkinetic. And it lost its middle. It lost its middle ground because it lost its internal structure. Yeah. So we have actually a paper which I think has a deep truth about mental disorders. Average is good, extremes are bad. And catatonia is an example where you oscillate between the extremes.
And then you talk a lot about ECT, so I'm wondering if you can talk to what ECT is. And there's just such a stigma about it. What would you want? Both with professionals and in the public, what you would want to tell people about ECT.
Yeah, ECT means electroconvulsive therapy. And yeah, it's also basically you give electrical currents to your brain. And that has been long regarded as a very bad treatment. There was a famous movie, Jack Nicholson, and that really discarded ECT. And in the 70s, in the wake of social psychiatry, where psychiatric disorders were not regarded as biological disorders, but as social disorders, ECT was, of course, completely discarded. And Max Fink really kept it up. And it is no doubt that ECT is a fantastic treatment for instance, treatment-resistant depression. Febrile catatonia, an absolute must, and also for non-febrile catatonia, which don't react to lorazepam. And also some use it also for schizophrenia. So I think it can be a very effective treatment. Unfortunately, we don't really know the mechanism. Yeah. Why? Basically, for me, it's like you reboot your brain. Yeah. You induce a seizure, which of course sounds terrible. You induce a seizure in a patient, but it seems the seizure is where your brain is completely synchronized, yeah, into one big part. Any regional differentiation is lost. And this probably gives the brain to reboot and to reorganize its different regions and timescales and frequency. So this is one of the working hypotheses we're currently pursuing using imaging, ECT, and neural network and computational modeling. Yeah, and that probably is, and in depression, for people not to slip back into depression, they use a maintenance ECT. And you probably have heard about cases like that. If you forget one maintenance ECT, people slip back into the catatonic state or into the depressed state. So no doubt, I can only really support that treatment. You won't use it in first line. You always would use lorazepam in first line if you want to use another drug in second line, but then relatively quick, also electroconvulsive therapy.
And I'm wondering, do you have any thoughts in terms of what ECT what the seizure might do in terms of the stress response that's happening in the body? Because that seems to be where the overwhelm comes from. Not always, but a lot.
Yeah, I mean, for me, of course, body and brain are closely related to each other, and the brain continuously adapt itself to the input from the body, like with the respiration or the heart. So it's really an alignment. And the same the brain does with respect to external stimuli. Like when you listen to music, your brain continuously adapts its own inner rhythm to the rhythm of the music. So what do? You tap the music and you move to the beat of the music. And even more important, you feel terribly good with that. Yeah, you become part of the music and you might even have a flow experience. Many musicians tell you that. And all that seems to be lost. That capacity is lost, for instance, in catatonia. They're not reactive at all because they don't move at all anymore. Or they're extreme, they're completely disconnected. And it seems that through the synchronization, the brain can be rebooted. And that probably makes it possible then over many sessions, 15, 10, 20 ECT sessions, basically that the brain become again responsive and can align or synchronize itself with the environmental context and with the own body. And that's what make you feel better. Yeah.
Wow. So now let's talk a little bit about the Catatonia Foundation. So what made you want to get involved with the Catatonia Foundation, and what do you hope that it can accomplish?
Yeah, I think first I must say it's an excellent initiative, and it's good it's coming from those people who have had experience with Catatonia themselves. It's basically a client advocate group, and I think that's a very excellent idea. And also that's first thing. Second thing, that Catatonia is often under-recognized, and that under-recognition has severe clinical consequences because you can treat it so well with either lorazepam or other, or like ECT, you can prevent. So awareness of catatonia can create a lot of reduction in suffering from it. So I think it's an excellent point. And third, the research of catatonia was always at the fringes. It's not a mainstream topic. It's much easier to publish in a very good journal with, I don't know, the 400 paper of the year about schizophrenia than with one really original paper of catatonia, which actually is clinically much more relevant. Because the editors, of course, follow the mainstream, same for the funding agencies. And it's very hard to get grants for catatonia, if not impossible, because people say, yeah, it doesn't exist anymore, or it's just fringe, it's so rare. But the fact that it is rare doesn't mean it doesn't need to research on it, particularly in a condition that you can treat so well. And it's so severe. Yeah, it's even more severe than in depression or anxiety. So please, all depressed, don't understand me wrong here, but it's really an extremely severe condition. Yeah. So I think it's an excellent idea to push it from that side. And I would wish that also more substantial research. There have been a lot of case reports in recent years. There have been very interesting studies on catatonia coming out, which is very good. And I hope that these studies can also a little bit converge in the definition and diagnostic of catatonia. It looks like that there are two rating scales which really are most prominently used. And I think that's a good development. And my belief is always, how can we really achieve progress in the realm of mental disorders? Many people say, okay, you just try out, you need to apply. I think for me, it's very important to understand the mechanisms. The mechanism means here psychological, the subjective experience, what I said earlier, that for instance, life events, affective control, then motive. So that gives you an idea where and how you would need to look for mechanisms, also then on the neuronal side and on the bodily side. And my hope is that we can better understand these mechanisms. They will probably lead to better differential diagnostic, and then also to better therapy and personalization of therapy. So we have certain predictive markers that you react very well to lorazepam and in that dosage. We have markers that you will not react to lorazepam, that you react very quick to ECT, meaning you will get right away in ECT, we don't even try the lorazepam. For instance, like that. That's what my hope is, that we can really personalize, customize the therapy, and really enter the realm of precision psychiatry, where it's not just a word or a phrase.
So I'm just wondering, because, and I know we're running late, but I want to ask this question because I think it's really, the world is changing and it's intense, and there, especially with like access to the news and everything that's happening, where I think people are, getting over capacity pretty easily. I'm wondering if you think because of that, we'll see more catatonia in the future.
Yeah, it's a very interesting thought, and I wouldn't wonder. Of course, I cannot say that, but definitely I would say that so in my terms, high frequency bombardment You don't have these little moments, even in the subway. You sit in the subway, everybody is doing this, yeah. You don't have these little moments of mind wandering. Yeah, your mind wants to try out, it wants to go into this direction. Let me compare that to a little child. So you have a little child, it starts to learn walking. So it goes into this corner, it goes into that corner. So, what is there? Oh, there's a strange Zoom running. They talk about something very strange called Catatonia. So, I want to touch the screen. I want to do this. Oh, there's somebody coming in the door. So I go there. So that's basically the way you have to imagine your mind. It constantly tries out and this and that. And that you need a certain freedom. You need a certain internal space for that you're not completely always bombarded by external stimuli. Because that, of course, then you follow the external stimuli, but in your inner life, you don't really develop an inner mental life anymore. You're completely dependent upon external stuff. And I think that I've heard it in many countries. I travel quite a lot all over the world because of our collaboration and students. And I hear it everywhere in the country that among the young people, anxiety, depression increases. It's shocking. Whether you're in Japan, in India, in China, recently I was in Spain, in Italy, in Germany, here in Canada, probably in USA too. You hear it everywhere. And I assume that is related to that. And that I could imagine it also to higher incidences of catatonia, particularly in those who are very vulnerable.
And what makes someone vulnerable?
We don't know that yet. We need the risk factors. As you know, there are different immunological mechanisms, inflammatory mechanism discussed as a basic causes of depression, of catatonia, and I would probably also my psychomotor mechanism, certain balances between dopamine and serotonin or certain subcortical cortical might make you vulnerable. That's what I mean. We need to research the mechanism, then also to discuss predisposing vulnerability factors.
Yeah, and I'm wondering also, like, you were talking about that the brain gets over capacity or the body gets over capacity, and overwhelm. Is there a way that you think we can, preemptively avoid that? Like, what can we do to avoid that kind of overwhelm, just in general?
Yeah, I mean, definitely. I mean, as I said, my patients whom I said, okay, always take a little lorazepam when you have the feeling you get overwhelmed. And ideally, we develop psychological mechanism. For instance, we develop here personalized breathing therapy for people with anxiety, where we tailor the individual breathing rate according to the psychological and neuronal features of the patients. And this is amazing. For instance, one of my severe anxiety patients, she's an engineer, and she's social anxiety, and she's always afraid. And she had one catatonic episode as part of that social anxiety. And she's always very afraid in public talks. She's a brilliant engineer. It's unbelievable how brilliant she is, but she's very afraid of public talks. So now I said, each time before you give the talk, you go to the restroom, do 2 minutes, your personalized, customized breathing protocol, and it helps. So these kind of little psychological things, so non-pharmacological therapies with immediate efficacy, we can give, for instance, for prevention. And I could imagine doing similar thing for catatonia. Or we develop customized, personalized music therapy for patients with depression. Same thing. So the advantage of these non-pharmacological therapies is that they have low side effects. And if used properly, you can use them, they have immediate efficacy. It's amazing.
Can propranolol be used in those instances too?
Excuse me?
Could Inderal or propranolol be used in those instances too?
Sure. There are studies on that and can also be used. I would always prefer first a non-pharmacological situation, but it also depends upon the subject. Some like a pharmacological thing, some are non-pharmacological. Yeah, but definitely propranolol, of course, makes perfect sense. And I know that there's some case reports also, propranolol and catatonia.
So this has been amazing. Are there any other thing you want to add? I'm just I'm so happy we had this interview with you and got to know you, really. Thank you so much.
And I'm happy to have finally met you. And I'm really sorry that I couldn't attend the other meetings.
You'll
So
attend when you can.
very good. Yeah. So I'm happy that we're there. And you can always contact me, let's say, if you have specific questions. You know that I reply to emails. Or if you say here, can we make a quick Zoom meeting for things, I'm happy to do that.
Oh, thank you. We
So I
appreciate
think
that.
you covered the territory very well, and I can only support you in, I really like your initiative. And I think what is important, follow your instincts. Don't always follow the mainstream, what people tell you. Follow your clinical instincts. Very important.
Thank you. I hope I get to meet you someday in person.
Yeah, I hope so too. You're in Michigan, or where are you?
Yeah, I'm in Michigan.
It's
Yeah.
not that far from. So where exactly? Yeah. So you're not that far from Ottawa. I mean.
No, I'm in the Detroit suburbs.
Okay. Yeah. Yeah.
Yeah.
Okay.
Well, we're gonna have to make that happen. I have to meet you someday because
You're welcome. Yeah. Thanks.
yeah. And thank you to Dr. Karoff. He's like, you need to get Dr. Northoff on this board. Like, he's super important to be involved. So thank you to him.
Okay. Thank you. Thank you.
He's an amazing man too.
Uh,
Yeah.
Same.
Thank you. Thank you so much. Anything we can do to support you too, we're here for you. We are so grateful to you.
Okay. Thank you. Same on my side. And as I said, don't hesitate to contact me. We can always have spontaneous Zoom. And good luck with
Perfect.
that.
Perfect. Thank you
Thank
so
you.
much. Have a
Yeah.
great weekend. Bye.
You too. Bye.